Postpartum hemorrhage. Hi, I'm Michelle.
Hi, I'm just Kirit.
Hi, it's Kamaljit.
Hi, I'm Sashna.
Postpartum hemorrhage is defined as the blood loss greater than 500 ml after vaginal birth or 1000 ml after cesarean birth, or a drop in 10% of hemoglobin or hematocrit after admission to the post delivery with sign and symptom of a hemorrhage. Most cases, hemorrhage occur immediately after birth, but some are delayed up to several weeks. So there is a early or primary postpartum hemorrhage which occur within 24 hours of birth, and the late postpartum hemorrhage which occur after 24 hours and within 6 weeks after the birth. So once the baby is delivered, the uterus normally contracts and pushes out the placenta. After the placenta is delivered, these contraction helps put the pressure on the bleeding vessels in the area where the placenta was attached. So if the uterus does not contract strongly enough, these blood vessels bleed freely. So that will cause a postpartum hemorrhage. Which one is the most leading cause of the death? Early postpartum hemorrhage. Early postpartum hemorrhage result from one of these three causes. First one is the uterine atony, which is the most common cause. A poorly contracted uterus that does not adequately compress large open vessels on a placenta side. This can lead to hemorrhage. This can involve anterior, posterior, or the both area of the uterus, which can lead to the hemorrhage. So, when the uterus may become atonic, which is maybe it's due to the medication wear off effect. On assessment, uterus is soft, high uterine fundus that is difficult to feel through a woman's abdominal wall, or heavy lochia, often with a large clot or sometimes a persistent moderate flow. Bladder distension causes the uterus to be high and usually displays is to the one side. Second one is the laceration or tears on a reproductive tract. When when there is a continuous trickle of blood that is brighter than the normal lochia. Fundus is that is usually firm. The onset of hypovolemic shock that may be gradual and easily overlooked. Number third is hematoma in the reproductive tract. Hematoma, which is visible to appear, it's a blue or purplish discoloration mass on the vulva, severe and poorly relieved pain and a pressure in the vulva, pelvis or rectum. A large amount of blood is lost into the tissues which cause sign.
Okay, for the treatment of anatomy, the first treatment is to massage the uterus until it's firm, and then the bladder is emptied to keep the uterus firm. Pressing toward the vagina will have any clots or blood pulled out. Catheterizing the woman if she has any trouble urinating, and for the nursing care of atony, um, examinations to correct and determine the source of bleeding before it worsens, and this is usually done in the delivery or the OR. Oxytocin, which is the most common drug ordered to control uterine atony. And we have other drugs, methergin, cytotec, intravenous calcium gluconate. The methergin increases blood pressure and shouldn't be given to a woman with hypertension. Intravenous calcium gluconate relaxes the uterus during labor. And the infant suckling at the breast stimulates oxytocin secretions naturally. For excessive bleeding, you can provide a uterine tamponade using an intrauterine balloon, selective arterial embolization, or surgical ligation of the artery. The woman should be NPO until bleeding is controlled. And on rare occasions, hysterectomy is performed to remove a bleeding uterus until in case of other measures aren't successful. And treatments for laceration, the healthcare provider should be notified of signs such as bleeding with a firmly contracted uterus. The injury is usually sutured in the delivery or operating room. Nursing care includes reporting signs and symptoms. Women should be NPO as well because she may need general anesthetic to repair the laceration. And if these lacerations aren't cured, genital trauma may cure and cause long term effects such as a cystocele, which is a prolapsed uterus, and it could also cause urinary incontinence. And we also have hematomas. Small hematomas usually resolve without treatment, but the larger hematomas require incision and drainage of the clots. To stop the bleeding vessel is ligated or the area packed with the hemostatic material. Tranexamic acid. This inhibits the breakup of clots that form and prevents new clots from forming. And this is usually given 3 hours after delivery. And the nursing care for hematomas, ice pack to the perineum. This is sufficient for small perineal hematomas. The nurse should observe signs and symptoms of excessive pain and vaginal pressure or inability to void should be reported. And the woman should also be kept NPO until healthcare provider examines her and prescribes treatment.
Then the late postpartum hemorrhage, which occur when after the 24 hours to the 6 week after childbirth, usually occur after discharge from the hospital and usually result from the following. First one is the retention of a placental fragment. So when there is a slower than expected return of the uterus to the non-pregnant condition, then there could be something wrong in the uterus. Infection and retained fragment of placenta are the common causes. And the number two is self-involution of the uterus. Signs of self-involution are fundal height greater than expected for the amount of time since birth, persistence of lochia rubra or a slowed progression through the three phases, pelvic pain, heaviness, fatigue. Medical treatment is selected to correct the cause of self-involution. And next one is the venous thrombosis. Venous thrombosis is a blood clot within a vein. It occurs in a 1 in 1500 pregnancies. In pregnancy, the level of fibrinogen and other clotting factor normally increase, whereas level of the clot dissolving factor is normally decreased, which cause the bleeding. Some women are at a greater risk for postpartum hemorrhage than others. Conditions that may increase the risk, which are overdistended uterus, and oxytocin is used to induce the labor when it's more effective on and will not leads the uterus to contract back. Operative birth, sometime it's there is a post-operative, then there is something left behind, any pieces of placenta, sometime accidentally some pieces are left inside. Then use of instrument as like forceps delivery, bladder distension, tissue trauma during labor, open wound to the placental insertion site, surgical incisions, increase pH of the vagina after birth. Here is a mnemonic for PPH. 4 P's, which one is tone, trauma, tissue, and thrombin. So I put this slide for a visual presentation so that we can remember there are 4 leading causes, which is tone, trauma, tissue, and thrombin. Here are the predisposing factors. So first one is the previous history of postpartum hemorrhage. Some women they have a postpartum hemorrhage in their early pregnancy, and now they are repeating their chances. They have a highest risk for hemorrhage. Then placenta previa, abruptio placenta, when there is a displacement of the placenta and which cause the bleeding. Overdistension of the uterus, polyhydramnios, multiple gestation, large neonate, because the uterus have to contract a lot. Maybe that could cause a rupture or any bleeding, infection, multiparity, dystocia, or the labor that is prolonged. Operative deliveries such as cesarean or a forceps delivery, intrauterine manipulation, sometime when they do, it will lead to bleeding. It will cause too much pressure on the uterus, which, or is there any vessels that can rupture and lead to a hemorrhage. So here are the some nursing assessments so that we can know that there is a bleeding. First and the major one is uncontrolled bleeding. Decreased blood pressure due to the hemorrhage, her blood pressure gonna decrease and increase heart rate. In the postpartum woman, they usually have a slow pulse rate. So we as a caregiver should have to suspect that one as a hypovolemic shock or infection if the pulse rate is greater than 100 beats per minute. Then there is a decrease in the red blood cell count we can see in a patient's lab. Swelling and pain in the vagina and the nearby if bleeding is from hematoma. When there is a formation of a hematoma, usually which one is the very painful, and there is a swelling, it's a bluish or purplish, this big huge hematoma, which will a sign that there is a bleeding or hematoma inside in near to the vagina or near to the vulva, which is a very painful. Sometimes it's not painful, but usually they are very painful. So here are some complications of postpartum hemorrhage. First one is anemia, which is the major one. So when there is a lot of blood loss due to the hemorrhage, patient will be anemic and we need to transfuse blood. And also due to hypovolemic shock, if sometime patient delay to come back, if it's a late postpartum hemorrhage, which will lead to death. Dilutional coagulopathy, which is a major one too. If there is any clotting factor or something, sometime patient is taking over the counter medication or coagulation disorder, fatigue, myocardial ischemia, orthostatic hypotension, and postpartum depression.
So, some of the risk factors of postpartum hemorrhage are they can include, but they're not limited to, would be shock, placental abruption, multiple pregnancy, infection, or even prolonged labor. According to the book, the major risk of hemorrhage is hypovolemic, which is low volume shock, which interrupts blood flow body, which interrupts blood flow body. Hypovolemic shock is when the body has low volume blood as interpreted by the book. This means that the woman can bleed to death if the bleeding is not stopped. Tachycardia is the first sign of hypovolemic shock after postpartum. Placental abruption is when the placenta is comes off the walls of the uterus before the baby is born. This can cause bleeding in the mother, leading to postpartum hemorrhage as well. Multiple pregnancies, which can include twins. The postpartum hemorrhage here would be when the blood vessels start flowing freely when the contraction of the uterus is not strong enough. Hypovolemic shock risk factors is one of the risk factors. This results from postpartum hemorrhage. Some of the signs and symptoms of hypovolemic shock would include tachycardia, which is usually the first sign of hypovolemic shock. The normal heart rate is usually between from 60 to 100 beats per minute. Tachycardia is more than 100 beats per minute. Bradycardia is less than 60 beats per minute. Blood pressure. This is when when there's a slight change in the blood pressure, such as systolic pressure decreasing and the diastolic is increasing. The normal blood pressure range is between 120 over 80 mmHg. Another would be blood flow. Blood flow stops flowing to organs that are not essential and start flowing to the heart and brain as they are the vital organs. This results in pale, cold, and clammy, such as moist skin. Reduced blood causes mental changes such as anxiety, confusion,
restlessness, and lethargy. Urine output decreases because blood flow to the kidney causes the kidney to start preserving fluid. Abruptio placentae. This is a bleeding disorder that is a risk factor that can cause postpartum hemorrhage. Some of the signs and symptoms would include such as when the normal implanted placenta prematurely separates. A partial would be when part of the placenta detaches. An abruptio of marginal detachment is when the edge of the placenta detaches. An abruptio of central detachment would be when the center of the placenta detaches. The total abruptio would be when the placenta completely detaches. And this damages the uterine muscle fibers that cause bleeding, which leads to hemorrhage further out. Another would be a placenta previa. This is when the placenta is developing in the lower part of the uterus, when ideally it should develop in the upper part. The signs and symptoms would include a first degree, which is marginal. This means that the placenta does not reach the cervical opening and is less than about 3 centimeters away. The second degree would be the partial, which means that part of the cervical opening is covered. The third degree is when the cervix opening is completely covered by the placenta. Bleeding. This will have bleeding that is obvious and it'll be bright red. The blood clotting in this one is normal, and the fetus may be in a different position, such as a breech or transverse lie. This causes hemorrhage when the lower uterine segment is not contracting as effectively to help compress the bleeding vessels. The hemorrhage and shock in the postpartum client. Notify the RN immediately, like stay with the client and have someone else get the RN or the primary healthcare provider. If the uterus is atonic, massage gently but firmly to cause it to contract. Elevate the client's legs to a 30-degree angle. Administer oxygen by non-breather face mask at 8 to 10 liters per minute. Monitor vital signs in empty bladder by catheterization if prescribed. Assist with administration of uterotonic medications such as oxytocin and prostaglandins as prescribed to increase the uterine tone. The assist with providing additional or maintaining the existing IV infusion of lactated ringer solution or normal saline solution to restore circulatory volume. The woman needs to have two patent IV lines, a second IV line using 16 to 18 gauge, and IV catheter may need to be inserted by the RN. Assist the RN with the administration of blood or blood products as prescribed. Insert an indwelling urinary catheter to monitor perfusion of kidneys. Assist the RN to administer emergency medications as prescribed. Prepare for possible surgery or other emergency treatments or procedures. Record the event, interventions instituted, and woman's response to interventions. The treatment depends on the condition that has caused the postpartum depression. So basically, the main goal of treatment with postpartum hemorrhage would be to find the root cause of the bleeding and taking action on that end to help stop the bleeding. The normal treatment might include massaging the uterine to induce contractions, or using oxytocin to help with the uterine contractions as well. Hypovolemic shock treatment would include stopping the blood loss, providing IV that will help with the fluid that has been lost, providing oxygen to help reduce red blood cells to start functioning normally, helping to slow the bleed. Blood transfusions, they may be needed, and massaging the uterus along with administering drugs such as oxytocin that will help contract and reduce the blood loss. For the multiple pregnancies, the same approach may be approached, as contracting the uterus plays a major role in stopping the blood loss after delivery. Massaging the uterus can help the body to pass the clots that have formed. Medications, again, such as oxytocin, can be used in this situation as well.
Interventions: assess and record the type, amount, and site of bleeding, count and weight prenatal pads, if possible, safe blood clots to be evaluated by the physician. Assess the location of the uterus and degree of the contractility of the uterus. Massage boggy uterus using one hand and place the second hand above the pubic. Review the records and note the certain conditions such as retained placental fragments, any lesions, abruptio placenta, etc. Monitor vital signs including diastolic and systolic blood pressure, pulse, and heart rate. Check for capillary refills and observe nail beds and mucous membranes. Measure a 24-hour intake and output. Observe the signs of avoiding difficulties. Observe for reports to perineal pain and or feel of vaginal fullness. Apply counter pressure on labia or perineal lesions. Maintain a bed rest with a evaluation of the legs by 20 to 30 degrees and trunk horizontal. Medical interventions. Oxytocin. Oxytocin stimulate the smooth muscle of the uterus and increase the force, frequency, and duration of uterine contractions. Oxytocin use in induce labor, control postpartum bleeding, manage an incomplete abortion. Adverse effects and contraindications. Oxytocin may produce uterus hypertonicity, resulting in fetal adverse effects. High dose may cause hypotension with rebounding hypertension. Oxytocin would not be used in a client who cannot deliver vaginally or in a client with hypertonic uterine contractions. In it is also contraindicated in the patients with active genital herpes. Interventions. Monitor vital signs every 15 minutes, especially the blood pressure and heart rate, weight, intake and output, level of consciousness, and lung sounds. Monitor fetal heart rate every 15 minutes and notify the primary healthcare physician if significant changes occur. The use of an internal fetal scalp electrode may be prescribed. Document the dose of the medication and the time it was started, increased, maintained, and discontinued. Document the client's response. Keep the client and family informed of the client's progress. Amabet sterile solution is a form of prostaglandin used to treat severe bleeding after childbirth. Also, it helps to control blood pressure and uterine muscle contractions. Contraindications. It is indications in a person with asthma and pulmonary disease, as it can cause acute bronchoconstrictions. Methergin. Methergin stimulates uterine vascular and small muscles, thereby causing constructions, decreasing bleeding, arterial vasoconstriction. Contraindications. Those who have hypertension, preeclampsia, and eclampsia. Misoprostol is another prostaglandin. It increases uterine tone and decreases postpartum bleeding. It can be administered sublingually, orally, vaginally, and rectally. Contraindications. The only postpartum contraindication to use the of oxytocin would be hypersensitivity to the drug. Next is blood transfusion. Cross matching and blood typing is necessary to replace the blood loss. Administrating of oxygen. If the woman is experiencing respiratory distress, administration of oxygen at 4 liters per minute via face mask would be prescribed by the physician. Surgical interventions. Surgical management is essential to remove the cause of bleeding and avoid further replication of the body fluid stores. Hysterectomy. In the worst case scenario, the uterus needs to be surgically removed to save the life of the mom. Suturing. This is necessary for extreme uterine autonomy to stop the bleeding.
Lochia. Lochia is a vaginal discharge after delivery. It is composed of endometrial tissue, blood, and lymph. Lochia gradually changes characteristics during the early postpartum period. We have Lochia rubra, Lochia serosa, and Lochia alba. Lochia rubra is mainly consists of blood, and it usually lasts 3 to 4 days after birth. Lochia serosa is pinkish because of its blood and mucus content. It lasts from about the 4th through the 10th day after birth. Lochia alba is mainly mucus and is clear and colorless or white, which lasts 10th through the 28th day after birth. The Lochia's characteristic is a fleshy or menstrual odor. The fundus should be checked for firmness, because an uncontracted uterus allows blood to flow freely from vessels at the placenta insertion site. Perineal pads with cold or warm packs are used. The pads should be checked every 15 minutes, should be counted and weighed, especially if the woman has excessive bleeding. 1 gram of weight equals about 1 milliliter volume of blood. Nursing care of Lochia, the woman should be taught changes and the amount of what to be expected. The woman should report any abnormal characteristics such as the foul-smelling Lochia with or without fever, Lochia rubra that persists beyond the 3rd day, heavy flow of the Lochia, and Lochia that returns bright red color after it has progressed to serosa or alba. And the medications that may be given to stimulate uterine contraction include oxytocin is usually given IV, methylorganovin is given IM. Mild analgesics is to relieve any after pains and should be given immediately after breastfeeding to minimize sedation and side effects of passing to the newborn. The newborn suckling at the breast, this releases natural oxytocin, which stimulates contractions, and any after pains persisting longer than 48 hours after birth should be reported. And we have key points that I pulled from the book. Postpartum women often have a slow pulse rate. The caregiver should suspect hypovolemic shock or infection if the pulse rate is greater than 100 beats per minute. The woman who develops hemorrhagic complications should be kept on NPO status until the HCP evaluates her condition, because she may need general anesthesia for correction of the problem. Saturation of a peri-pad within 15 minutes to 1 hour after delivery should be promptly reported. Perineal pads containing cold packs absorb less than regular perineal pads. To best determine blood loss, weigh perineal pads before and after applying them. 1 gram in weight equals about 1 milliliter in volume of blood loss. I also have more key points here that may show up for NCLEX. A constant small trickle of blood can result in significant blood loss, as can a larger one-time hemorrhage. Pain that is persistent and more severe than expected is characteristic of a hematoma in the reproductive tract. Types of obstetric shock include cardiogenic from anemia or cardiac disorders, hypovolemic from hemorrhage, anaphylactic from a drug response, and septic caused by puerperal infection. Activity time!